also busy like that. When on ground, when you're doing management, you are busy like this, as these slides are very busy. You are, okay? So coming to the chronic complications of diabetes. So diabetes can cause many common complications. It can cause stroke, heart attack, peripheral vascular disease, retinopathy, cataract, glaucoma, diabetic foot, neuropathy. So diabetes on long term can cause the diseases in almost all the organs of the body. And in case of the type 1 diabetes, all of these chronic complications, they appear almost 10 to 12 years after the onset of the type 1 diabetes, depending on the type of control the patient is having. But in case of type 2 diabetes, when the type 2 diabetes is diagnosed, at that time, patients have developed these complications, and within 5 years, these are apparent, because type 2 diabetes is actually, there is a lot of longer time period of pre-diabetes before type 2 diabetes, and that pre-diabetes is a time period in which the slower damage to these organs is taking place. Slowly, gradually, these are being damaged. So usually when type 2 diabetics, within they they are diagnosed, they might have the retinopathy or neuropathy or nephropathy at that time of diagnosis, at the time of the diagnosis, or within 5 years they will develop, they will develop these complications. So biology of the macrovascular injury: metabolic injury to the large vessels. So we have macrovascular and microvascular injuries. The macrovascular is because of the injury to large vessels, which is heart, coronary artery disease, coronary syndrome, MI, and congestive heart failure. In brain, we can have the patients have cerebrovascular disease, strokes, extremities, peripheral vascular disease like ulceration, gangrene, leading to amputations. While microvascular diseases or microvascular is because of hyperglycemia. This is occurring in eye, leading to retinopathy, cataract, glaucoma, which in turn leads to blindness. Kidney leads to nephropathy, which is macroalbuminuria, then gross albuminuria, then kidney failure. And nerves, we have neuropathy, peripheral neuropathy, autonomic neuropathy, which can lead to amputation, and all of these in turn can lead to death or disability. So microvascular complication, their main risk factors, modifiable risk factors are metabolic control. So if sugar is controlled, the diseases can be controlled. Hypertension, hyperlipidemia, and smoking, if these are controlled, then the progression of macrovascular diseases can be controlled. Non-modifiable are type of diabetes, duration of diabetes, insulin treatment, nephropathy, pregnancy, puberty, genetic factors. These are non-modifiable. So if patient develops pregnancy, the chances of progression of retinopathy, of nephropathy is very high in these patients. Then when patient is going through puberty, then the chances of progression is high. If already there is a kidney disease, if already there is a kidney disease, these patients have higher chances of nephropathy, development of nephropathy. So coming to the first microvascular complication is retinopathy, which is due to damage to the blood vessels in and around the retina. It could occur with varying degree of severity. So this is a normal retina, clean retina, that's the optic disc, and that's the fundus, and you can see the vessels are very nicely visible. There's no hemorrhage, nothing. Now this is small hemorrhages. You can see the dot and blot hemorrhages can be seen, and the vessels are becoming tortuous. There's new vascular formation going on, the new vascularization. Cotton wool spots, hard exudates can be seen. And then we have large hemorrhage. This is a large subhyaloid hemorrhage can be seen, which causing dramatic vision loss. So according to the guidelines, we have stages of the diabetic retinopathy. Normal fundus, macular edema. So this is macula, the area which takes up the maximum uh, vision, which has the maximum vision, macula. So diabetic macular edema may coexist with either non-proliferative or proliferative diabetic retinopathy of any severity, and retinal thickening may be assessed stereoscopically. So in normal fundus, this is normal fundus, there is no macular edema. This is a macula, and the edema of this macula can be present at any stage. Okay? So this normal fundus UK equivalent, it is called RO. Then moderate non-proliferative diabetic retinopathy is of two stages, mild or moderate. Mild when there is just microaneurysm, little bit of small aneurysms. Take a little bit of small aneurysm like this. You can see there are small dilatation of the vessels. Moderate is more than just microaneurysm but less than severe. So it's in between the moderate is in between the mild and severe. This one is moderate. Okay? Then severe and severe non-proliferative, more than 20 intraretinal hemorrhages in each of the quadrants. You can see these hemorrhages, venous beading, and IRMA. IRMA is in one or one plus more than one quadrant, and no sign of proliferative diabetic retinopathy. So what is proliferative? It has all these features as well as new vascularization or vitreal pre-retinal hemorrhages. So there is new vessel formation, tortuous vessel formation, and there is hemorrhages taking place in the vitreous or pre-retinal area. This is called proliferative diabetic retinopathy. IRMA is intraretinal microaneurysms. Okay? So medical management, we can do photocoagulation, laser treatment, we do control the hypertension, control blood glucose, and there should be no smoking. It can be expected. The treatment, by treating, there are odds are good, patients can improve. Patient require frequent eye examination. Bilateral disease is usually there, but it is uneven. So one of the eye can have mild or moderate non-proliferative, and the other eye will have proliferative diabetic retinopathy. Other optic complications can be cataract, lens changes, extraocular muscle palsy, and glaucoma. So nephropathy, in nephropathy, what happens is that the diabetes, the high sugar levels, they cause damage to the glomeruli, which results in loss of protein. Diagnostic value, normal microalbumin level is 30 milligram per 24 hours. So when it starts rising, then it is microalbuminuria, more than 30 milligram, and then when it starts rising, wait. So when it starts rising, it means that the patient is developing nephropathy. This can lead to kidney failure. So what happens is there is a clinical triad. There is nephrotic syndrome, there is end-stage renal disease, and there is diabetes, hypertension. So altered barrier function, the podocytes get damaged, the glomerular basement membrane becomes thickened. So first there is normoalbuminuria, then microalbuminuria, and there is then frank macroalbuminuria, and patient has nephrotic syndrome. There is impaired GFR, the glomerular filtration function is impaired, and so impaired GFR, which occurs because of the mesangial expansion and glomerular sclerosis. This initially leads to increased GFR, then there is a stage in which GFR becomes normal, and then it falls. When it starts falling, then it is end-stage renal disease. It can cause along with this, they have raised systemic blood pressure. It can be essential, or it can be because usually in type 2 it is essential hypertension, while in type 1 it is because of the renal damage. It happens, it is secondary. Patients can have normal blood pressure, borderline blood pressure, and then they have hypertension. So what is the management? Tight glucose control, antihypertensive like calcium channel blockers, alpha blockers, and ACE inhibitors. Alpha blockers and ACE inhibitors are considered better drugs. They have shown better results, and they have also shown in they have also shown to play great role in prevention of progression of disease, nephropathy in diabetic patients. Patients then in the end might need dialysis, or they can go for transplant. Prevention is by controlling the blood pressure, the blood glucose. If there is recurrent UTIs, they are predisposed to recurrent UTIs, that should be controlled. No nephrotoxic substances, so the drugs which can cause nephrotoxicity, they should not be given. Sodium and protein intake should be decreased in these patients. Coming to neuropathy, nerve fiber degenerates and blood vessels supplying the nerves are grossly diseased. They are classified as symmetrical, focal, and multifocal, cranial, asymmetrical, low limb, truncal, and limb mononeuropathies, diabetic, asymmetrical, proximal motor neuropathy, hip, knee, back pain, loss of reflexes. There is also another classification, autonomic neuropathy. It can be sensory neuropathy, it can be motor neuropathy, it can be mononeuritis multiplex. These are the various ways it can occur. The presenting features can be the loss of sensations, or it can be paresthesias, or it can be burning sensation, tingling sensation, it can be um, pain, severe pain, burning sensation and pain. This can present as nerve damage, as foot drop, wrist drop. The most common cranial nerve involvement is of third nerve and sixth nerve, so it can present with, with ptosis, with diplopia, which are temporary, which get improved after some time. With treatment of diabetes, they improve as well. So the management is to control the serum glucose levels. Pain needs to be controlled. So analgesics, tricyclic antidepressants, and anticonvulsants are the drugs which are used to control the pain. So how is this happening? Okay, we'll skip this. We'll just go to the next one. So the cardiovascular diseases, major source of mortality in patients with type 2 diabetes. Approximately 2/3 of people with diabetes die of heart diseases or stroke. Men with diabetes face a twofold increased risk for coronary heart disease, and women have a 3 to 4-fold increased risk. Diabetics more likely to develop MI, congestive heart failure. So this 3 to 4-fold increased risk occurs in women after menopause. Premenopausal women don't have this. Postmenopausal women are the one which will have 3 to 4-fold increased risk. About 2 out of 3 people with diabetes die of heart disease, 2 to 4 times higher risk of stroke, and this is all because of the atherosclerosis. Hypertension affects 20 to 60% of all diabetes, and this hypertension in turn increases the risk of retinopathy and nephropathy. Diabetes also increases the susceptibility to infections. Predisposition is combined effect of other complications, so neuropathies, nephropathy, they all are leading to this. Usually the neuropathy is leading to the complication infections. Normal inflammatory response is diminished, slower than normal healing. Periodontal disease, dental diseases, dental abscesses is very common. Foot ulcer infections are very common, very important to take care, otherwise they can lead to amputation and loss of feet. It is due, and these are due to the other. This is because of the other complications, chronic complications of diabetes. So diabetic patients are immunocompromised because WBCs, the TLCs, the white cells, which are the fighting cells, because of the hyperglycemia, they become sluggish. They become their functioning is affected. Once that occurs, they're difficult to treat. The ulcers, when occur, it is difficult to treat. The infection is difficult to treat because of the poor circulation, because of atherosclerosis. Antibiotics, they do not get there because of the atherosclerosis. There's sluggish WBCs. Then the wounds, we do not know where exactly the wounds are. The concern is basic. The foot infections and foot wounds are of particular concern. High risk for foot infections depends on duration of diabetes, increased age, smoking, decreased peripheral pulses. So peripheral vascular disease if present is at high risk. If there is decreased sensation, so if there is neuropathy, if there is already deformities, or there are pressure areas, if there is history of foot ulcers, so then there is high risk for foot infection. How the progression takes place: first there is injury to the soft tissue. Injury, there are it is not sensed. People do not don't get the sensation of warm or cold. Then these areas, they get infected. There is drainage, swelling, and redness. There can also be gangrene because of the atherosclerotic disease. So high risk foot infections also, the complication, two main chronic complication which leads to the foot infections is neuropathy and peripheral vascular disease. Neuropathy will cause decrease the pain sensation, which decreases the pain pressure sensation. These two sensations are decreased. Autonomic dysfunction causes the dryness. This all leads to fissure. So they will not know. We get patients who have put their foot on while traveling on the bike, have put their foot on silencer, and they are getting burned, and they will not know that the foot has gotten burned. Or they're wearing shoe with the stone in it, and they will not feel that stone. Or if something enters the shoe like a nail, they will not feel, and that nail will damage them. They will not know. The foot will be bleeding, and they will not know that they have been injured, because there will be loss of sensations. Peripheral vascular disease, there's decreased circulation because of atherosclerosis. Sluggish WBCs are there. Oxygenation is not taking place, which leads to poor wound healing, and you need to give antibiotics, but still, and this leads to gangrene formation. So this is the diabetic foot ulcer. ठीक है, neuropathy है इधर, and this is the gangrene. So vascular disease है. Gangrene is the death of tissue in the parts of foul smelling discharge, and these are usually dry wounds. So जो the neuropathy होती है, उसके जो wounds होते हैं वो wet होते हैं, because वो उसमें ब्लड सप्लाई होती है. मगर जो पेरिफेरल वेस्कुलर होते हैं वो ड्राई गैंग्रीनस होते हैं, क्योंकि उसमें ब्लड सप्लाई नहीं होती है. इसमें पेन होता है न्यूरोपैथिक में. इसमें न्यूरोपैथिक में पेन नहीं होता है. पेरिफेरल वेस्कुलर डिजीज वाले में पेन होता है. यूजली जो डायबिटिक फुट आते हैं उनको दे हैव बोथ पेरिफेरल न्यूरोपैथी as well as peripheral vascular disease. This is another foot. You can see there is a gangrenous involvement, and there is edema around it as well. So this is kind of a combined diabetic foot. So what else can happen? They can have boils, also known as furuncles, round pus-filled bumps on the skin, and usually staphylococcus and staphylococcus aureus bacteria is responsible. They can have cellulitis, non-contagious inflammation of the connective tissue due to the bacterial infection. So treatment is antibiotic and analgesics. They can keep on having UTI, yeast infections, periodontal diseases. Then there can be gangrene, not only of the foot, but of the hand and of the finger as well. Management is bed rest, antibiotics, which can be given by topical or IV, debridement, good glucose control. Sometimes foot needs to be amputated. Teach foot care. We have to teach these patients about their foot care, how to prevent. That is very important. teach the wound care as well. Then they have to learn about the special footwear has to be given to these patients, which causes with these special footwear are offload, they offload the wound. So what the footwear is made in a way that the area which is wounded, you cut out, the shoe is cut from there and a gap is created so that the wound doesn't directly come in contact with the foot sole, the shoe sole. So that's how. And then daily dressings and debridements need to be done. So this has to be taught to these people. So the daily the foot care which these have to do is that they have to be told that, look, you have to take care of your feet like you take care of your face. You have to wash them daily, dry, especially between the toes, feel for bumps and feel for temperature change. So if you feel, look between the toes and check each toenail. File toenails straight across. So do not cut the toes in like, keep them straight. Do not cut them like this, like the curve we make. Do not do that, but make it in a straight line. Check for dry and cracked skin. Look at the bottom of the feet. If you cannot look, turn them, take a mirror, use a mirror. Track, make a note, a care log. So all these complications can be prevented by managing the diabetes, by lowering risks for conditions, routine screening for this complication, and implementing the early treatment of these complications. We can prevent all of these complications. Thank you. If you have any questions, I hope you have understood the diabetes. Diabetes is a very big topic. It's kind of a whole medicine in one disease. So I've tried to cover everything. If you want me to talk about something else, if you don't understand anything, you have 1 week's time. Please go through these lectures, go through your books. Any questions you have, just type that in, and I will go through them and I will answer them accordingly. The next lecture of which we will be doing will be another diabetes, not diabetes mellitus, but will be diabetes insipidus. So have a good day, all of you. Allah Hafiz.